Well, another day, another question in my DM that I'm going to try to answer in this Facebook Live video. It's a light OR day today, which I always welcome because doing 7 or 8 cases a day, at my age, it's tiring. I have to pay a lot of attention to every single case, take care of the patient before, during, and after, and also talk to the family. It's tiring at my age. So this is a welcome break when I get a question that I get the opportunity to answer in a Facebook Live. And today's question came in my direct message on Facebook, and the question goes something like this. I had a question I was hoping you could help me with. What are the potential issues with medical assistants and LVNs, licensed vocational nurses, not RNs, entering diagnoses in electronic health medical record charts? I see a whole list of problems with it, including compliance, medical legal stuff, etc. But I wanted to get your input. Thoughts? Well, I'm going to give you 3 risks and 3 benefits of having the MAs and LVNs enter diagnoses in your electronic health records. And for those of you who do not know me, my name is John Lin. I'm a urologist in Gilbert, Arizona, also your humble host of the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit. And it's all for free. And when they say it's free, I say it's for me. All right, let's get into it. Risks. Number 1, inaccurate or incomplete diagnoses. Whenever you have your MA or LVN enter diagnoses in the EHR, they may have limited training and or knowledge compared to physicians or APPs, advanced practice providers. This could increase the risk of errors or misdiagnoses, leading to inappropriate treatments or possibly patient injury. Second risk, and as the person mentioned already, legal and liability concerns. If a MA or LVN enters an incorrect or inappropriate diagnosis, it could lead to legal and liability issues. The responsibility for accurate diagnosis typically lies with licensed healthcare professionals such as physicians and APPs. And in case of a lawsuit, guess who they're going to go after? Not the APPs. They may be named in the lawsuit, but they'll go after the physicians or possibly even another entity with deeper pockets, the hospital. When you delegate the selection of diagnoses in the EHR to individuals with lower training levels, this may pose some legal risks. And number 3, quality of care concerns. Now, the EHR plays a crucial role in healthcare decision-making and sometimes in research. Inaccurate or incomplete diagnoses entered by the MAs or LVNs could potentially impact the overall quality of patient care if the healthcare providers rely on incorrect information for subsequent treatment decisions. So those are a few things that you need to consider when it comes to risks. Now, there are a lot of benefits, in my opinion. And these are, number 1, efficiency and workflow optimization when you have the MAs and LVNs enter diagnoses in the EHRs. When you have them do so, it can help streamline administrative tasks for physicians and APPs. This delegation of responsibilities can free up time for physicians and APPs to focus on direct patient care and not potentially, but definitely improving overall efficiency of your practice. It's been said that everyone needs to practice at the top of her license. The ability for MAs to document in your electronic healthcare, of course, depends on the allowable scope of practice in the state in which you practice. Now, let me give you some examples where my medical assistants help me in documenting diagnoses and picking CPTs when they're performed, procedures that are performed in the office. For instance, when intravesical BCG is being administered in the office, my MA pulls down in the assessment and plan section the diagnosis of Encounter for anti-neoplastic immunotherapy, Z51.12. And she includes under that diagnosis bladder installation of anti-carcinogenic agent, CPT 51720, and 50 units of BCG live intravesical installation, J9030 times 50 units. Now, that may seem like a lot of information for a medical assistant to enter. Of course, I try to make it easy for everyone to enter that information and capture all that data. The ability for my MAs to do that easily is partly because I've empathetically templated what they have to do to make it very easy for her to document. My MAs have their own assessment and plan preference/shortlist. That means they're not going out to search for the CPT, the diagnosis, the J code, HCPCS code, whatever it is, for something that they routinely do. Now, this can be safely performed if appropriate training is done for the MAs, with the MAs. And of course, you want to choose the MAs who are intellectually capable of performing these tasks by bringing the diagnoses into the EHR assessment and plan. Let me give you another example. And this is in telemedicine, something that I'm still doing a lot of, even after the supposed ending of the public health emergency on May 11th, just a couple of weeks ago. Telemedicine pre-visit documentation is done by my medical assistants. I only see follow-up patients in my telemedicine visits. And personally, I think that's the best way to go because I don't have many patients who have to travel from far away to come to see me. So seeing these patients, these follow-up patients, where I've already established a diagnosis and I document under the initial visit under the diagnosis, why the patient needs to come in for telemedicine follow-up. So under the diagnosis, under the ICD10, it says virtual visit in X number of weeks. And it is very easy for the medical assistant to look at the previous record and say, that is why Dr. Lin wants to see the patient. She will easily bring down the diagnosis in assessment and plan as per my previous documentation. Super easy. She captures and verifies the past history, and she goes over the consent process for the telemedicine visit that is about to happen that same day. So the information capture is correct, updated, contemporaneous, and relevant. So that's another instance where my medical assistants are documenting in the electronic health records the diagnoses. So second benefit of having the MAs and LVNs document the diagnoses in the electronic health records is that it enhances documentation. MAs and LVNs can assist with capturing patient information, procedures ordered and performed in the office accurately and properly. Entering diagnoses in the EHR can ensure that important details are documented in a timely manner, contributing to comprehensive and up-to-date patient records. In addition, this may help decrease the 1,000 clicks of death that we all do as physicians in our daily EHR documentation by appropriately offloading these more menial tasks. When the diagnoses are already captured by somebody else and in the assessment and plan section of my EHR, it is much easier for me to include that ICD10 in any appropriate imaging or lab order that I may select for that particular visit encounter for that patient. Whenever you are doing things more than once, you need to be asking, should I be doing it? And if you don't have to be the one doing it, delegate it. The second question you should ask is, should I be doing it? And if you don't have to do it, stop doing it. All right. Lastly, the third benefit of having ancillary staff entering the diagnoses in the EHR is that this allows the MAs and LVNs to to enter the diagnoses and fosters teamwork and collaboration among healthcare professionals. It enables a more coordinated approach to patient care with different team members contributing to the documentation and decision-making process. This also teaches the ancillary staff the importance of documentation when rendering care as it relates to the entire revenue cycle. As you know, if it's not documented, it is not done. Now, this applies to revenue cycle, coding and billing, as well as medical legal perspectives. So no matter who enters the diagnosis, ultimately the buck stops with the qualified health professional billing for that service. And most commonly, that'll be the physician. And sometimes the APP, Advanced Practice Provider. Now, if this makes sense to you, or if you want to learn more about how to improve your practice and run your practice better, I would recommend that you consider attending the Texas Urological Society meeting being held in Austin, Texas, June 8th through 10th, where yours truly will be presenting and including the performance of a magic trick on coding and billing. The coding lecture will be based on fact and rules and regulations, but I'll be using magic as a metaphor in my presentation. And if you're wondering, how in the heck does he do all of this video stuff, the Facebook Live stuff, and how does he do it? Well, let me share with you, this is what happens in the background. One computer, multiple monitors, and multiple cameras with a sound mixer and something to select cameras with. And what you don't see is something underneath his desk, which is a pedal that I can use to select the different camera angles. I know I'm very curious when I'm watching somebody's live streams, how are they doing all of this? And if you're interested in any of this tech stuff, please reach out to me directly. I'll be happy to help you. Another source of information for you to master and to be better at running your practice, coding and billing, is at the Uorlogy Advanced Coding and Reimbursement Seminar. There'll be 2 sessions that will be held, one in December of this year in Las Vegas and one in January of next year in New Orleans. Now, the New Orleans seminar, the location varies. I've seen it being held in Florida as well as New Orleans, but it seems like the last few years has been in New Orleans, which is a great location as well. Lots of things to do during the evenings when the presentations are over, and you always walk away with amazing information. And I warn the attendees before they show up that it'll feel like you're drinking from a fire hydrant. There's so much information thrown at you. And for me, someone who is very, very simplistic, I don't know how I got into medical school, and I don't know how I got into urology. By the grace of God, I don't know how I got into it. But for me, when it comes to coding, billing, how to run your practice better, I need repeated exposures. I can't just see it once often. I can't see it just once and be able to solidify that information in my brain and be able to, most importantly, apply it. So for me, I had to, over the years, attend these meetings multiple times to finally make that E&M information concrete in my mind, make that modifier use information concrete in my mind so that I know I am safely and efficiently coding and billing and maximizing revenue, maximizing efficiency. Heck, you did the work, you might as well be paid for the work that you performed. Thank you so much for the privilege of your time. Thank you so much for watching. As usual, please take care of yourself and take care of each other. Bye-bye.